Hello, everybody. Very nice to see everybody here in the room, and also to those of you that are watching live online, and also those that will follow up on catch up. So we're here for a wonderful occasion, and I love inaugurals, and I have to say I've been looking forward to this one very much. I'm Jenny Hyam. I'm the Vice Chancellor of St George's. And as we'll hear in the story, we've had a long collaboration initially with Kingston, and now we're pure St George's, and we'll hear a lot about that journey. When you first arrive at an institution, you meet people and you sort of form an opinion about people. And I remember meeting you very clearly early on after my appointment here. And you were warm, intelligent, welcoming, and hugely knowledgeable. I established that feeling about you from the first time I ever met you. So the fact that we are now here together to celebrate this enormous achievement of you receiving your chair is, for me personally, something that I feel extremely warmly towards you. And not only that, because she also has a secret life on the terraces, yelling her head off as a gooner, and I'm a gooner. Come on. And another thing that you can tell about people is the sort of people that they attract in the room and the atmosphere within the room. And it is lovely, and people have travelled far and wide for you to enjoy today. We'll hear the story, but the great thing is, because it's an inaugural, no clever questions. If you've got your clever questions, you can do it over a glass of tepid wine next level when it's finished. So please do join us. Fiona is going to give the vote of thanks, and thereafter there'll be plenty of opportunity for everybody to catch up. So over to you.
So much, Jenny, and thank you to so many of you that are here and people who are online as well supporting me. Now, I might have a bit of presentational dyspraxia here because my notes are here and my slides are there, but you'll just have to bear with me. It'll show me as a real human. So, some of you are familiar with my platform for practice concept. By this, I mean the synthesis of knowledge, skills, experiences in and outside of work, and personal factors, our qualities, attributes, preferences, which underpin our professional practice. I want to share some key aspects of my platform for practice, developed across the clinical, leadership, and academic threads of my career. Threads that I have to confess have been interwoven with a good dose of uncertainty. Inevitably, given the dimensions of a platform for practice, there'll be some professional and some personal stuff. One of my personal tendencies is to overthink. It's sometimes my superpower, but it's often my Achilles heel, particularly outside of work. And the people who probably know that most are Chris and James and Marcus, who's running late. Thank you for anchoring me, humouring me, and supporting me. So many of us, let's go back to this time last year, many of us were part of a joint faculty employed by Kingston University, based here at George's, delivering St George's validated programmes, knowing an amicable but complicated separation was coming. The Kingston University promotion round opened in the early process of a consultation about that dissolution. And although we were encouraged to consider promotion, regardless of which university we might be part of ultimately, it really did feel like there was too much uncertainty to be able to give that application my best shot. Plus, my lovely mum was fading fast. As the January deadline approached for promotion, mum was literally struggling to say more than one or two or three words probably per breath. And she insisted on the breaths that she did have. You must, because associate professor is such a mouthful. Parenting me to the last. So I pulled an application together and was able to reassure Mum that I'd submitted it before she drifted gently away 3 days later. And a word here for Marie Griffiths and the ICU team at Maidstone Hospital, who were absolutely exemplary in the end-of-life care that they provided her with. So fast forward to summer 2022, and Kingston's parting gift to me was to promote me to professor, not because of my returnable research, but in the domain of professional practice. And St George's welcoming gift was to honour that and provide me with this inaugural opportunity, which gave my dad something to smile about and my brother something to puzzle over. I am an atypical professor for St George's. I'm an allied health professional, an AHP, which is what that logo on the left represents. In the NHS in England, the cranberry dots represent 14 professions, and I'm not going to list them all now, you'll have to Google them. And we're mostly registered with the HCPC. In fact, you'll see 15 different roles described increasingly. One of those cranberries is speech and language therapy, which is my professional background. I'm not the first or the only AHP to be a prof at St George's. There's certainly some physios here, including, of course, my good friend Fiona. And but I think I'm the first speech and language therapist, and for a long time the only one in the academic side here at St George's. And I'm really delighted to see so many allied health professions colleagues here in the audience supporting me today. So thank you so much for coming along. Being an atypical professor is really important. It challenges misperceptions. I'll read this because the print is quite small, but it's a screenshot from the House of Lords Committee at the end of last year looking at clinical academia. And it opens with clinical academics are qualified doctors who combine working as a specialist doctor with research and/or teaching responsibilities. Maybe they don't mean medical doctors, but probably that's how a lot of people will interpret that. Clinical academics are not exclusively qualified medical doctors or exclusively working in hospitals. We are health professionals of all kinds, working across the diverse clinical context found across the NHS, and both clinical academia, the NHS and patient care is all the richer for that. So, how did a speech and language therapist get here? You might not be the only one scratching your head. Here's the platform for practice idea again, in some work I produced with Liz Treadwell, there you are, who's the professional lead for physiotherapy here at St George's, and Stuart Palmer, then professional lead at NHS-EI, now director of all age continuing care for NHS Sussex. In this work, we identified factors important for the development of AHP leaders. And there are two categories here which I think are important in my platform for practice: my professional clinical foundations and the mid-career opportunities which I had. So my professional and clinical foundations, this is a bit of catalogue of crazy haircuts, by the way. I graduated as a speech and language therapist from the University of Sheffield in 1990, and the first people I met there were Rosalind and Maria, who's sitting in the middle there. And I think they probably confirmed that there was quite a lot of uncertainty about whether I wanted to be a speech and language therapist. I'd actually been quite interested in being an architect at school, but ended up meeting one in Sheffield instead. I started applying for management trainee posts during my final year, but eventually did decide to give speech and language therapy a go. I had a ball in Sheffield. We had great fun in Sheffield, and I'm always finding good personal and professional reasons to return. As a newly qualified therapist in the early 90s, it was when cognitive neuropsychology was revolutionising aphasiology, how we understood language loss after stroke, for example. I was quickly uncertain about whether I understood and knew enough about this, and within a year of qualifying, enrolled on the MSc Cognitive Neuropsychology at Birkbeck College, University of London. I was then fortunate to join other Birkbeck Cog Neuro alumni, Carol Pounds and Jenny Sheridan, thank you for coming along, who generously welcomed me into their team, and I joined them in delivering what were at the time the go-to workshops for speech and language therapists to use Cog Neuro in assessing aphasia and supporting speech and language recovery. Much of my clinical speech and language foundations were formed at Atkinson Morley's and the Wolfson, which included being involved in some of the early language testing in neurosurgery for embolizations and awake craniotomies carried out by speech and language therapists. And I know there are therapists here who are still involved in that work. It's great to see that. I loved that speech and language therapy role and assumed then that that was my career direction, as my publications from that era indicate. It was also at Atkinson Morley's that a more experienced neurophysio colleague, Fiona Jones, took me under her wing, and probably the time when I realised the professional and patient benefit which can be achieved when colleagues work collaboratively across traditional professional boundaries. And this was also the era when I met Kathy Sparks. There you are. Supervision champion and personal construct psychology guru who first introduced me to the idea of supervision. The arrival of small people prompted a relocation to the Garden of England, where willing grandparents were keen to lend a hand. I joined a newly established inpatient neuro rehab service as the speech and language therapist. And within a few months, the service manager left to relocate with her family. And the director of service, Judith Walker, I'm so delighted to see you here, asked me to consider acting into the role of inpatient services manager. As publications from that time indicate, my platform for practice was diversifying away from a dominant focus on aphasiology. The acting role became permanent, and over the next 12 years, my leadership portfolio grew beyond inpatient neuro rehab to include regional amputee services, wheelchair services, equipment services, and the establishment of neuropsychiatry. There is a bit of a speech and language therapy postscript, and between 2017 and 2019, Jackie McRae and I, Dr. Jackie McRae and I, who are both trying to get our PhDs over the finishing line, job shared the professional leadership consultant speech and language therapy post here at St George's Trust, in which I should stress you were the speech and language therapist, the majority shareholder, and I was doing the kind of professional leadership piece. So back to the service management leap of faith. If this is Marcus, he's arrived right on time. So it's only now in the preparation for this lecture that I recognise how well the mid-career leadership opportunities we described in 2019 really describe my own leadership development during those 12 years. So I don't know how clearly you can see the things at the bottom there, but managing inpatient services in a multi-professional team rapidly widened my professional perspectives and tested my taken for granted professional boundaries. And that was only possible with the support of an incredible champion and mentor in the shape of Judith, who was frankly taking her own leap of faith in appointing me. The service grew, we added more inpatient capacity, we moved into new premises. There were consultant-led neuropsychiatry services, as I described. As I took over other services and had responsibility for other services, there were lots of legislative changes, merging teams, closing services, so much to negotiate and so much to learn and add to my leadership platform for practice as I was building a service leadership track record. Looking back, what was probably a gap was some formal learning, but I was about to make up for that. Around 2007, I started to realise that the work-life thing was not quite in balance. And for those of you who are thinking, how do we navigate these kind of portfolio careers and knit them together? I think it's really important for us to own up to those moments when it feels like it's not quite going to plan and the uncertainties are maybe getting the better of us. I wasn't sure what my next step was, so I was playing what I call fantasy job hunt. And noticed that Fiona Jones, who'd nurtured me, multi-professional me back at Atkinson Morley's, was by now a principal lecturer in the School of Physiotherapy at Kingston and St George's. And she was advertising for someone from another profession to join the multi-professional MSc rehab teaching programme. This felt like an opportunity to use my platform for practice in a new and interesting way, although if I'm honest, I wasn't completely certain how. And it turned out not to be a brilliant time to find yourself teaching policy and practice in healthcare at the end of the Labour administration as the coalition ushered in the Lansley reforms, if you remember those. It was a steep learning curve. There was so much research and theory which would have been really helpful in my leadership role and which I had no idea existed. Make of that what you will. But I often described it as getting into the cognitive spa. So Jill Mean, and I've seen you here somewhere, there you are. Jill Mean, who's a nurse, midwife, health visitor and researcher, and I infiltrated School of Physio. And we did some innovative things, I think, during that time, like adding a lay summary or a plain English component to assignments, using action learning as a way to support post-registration learning, developing award-winning quality improvement short courses for allied health professionals, which were co-designed and co-delivered with practice and NHS arm's length body colleagues. Collaborators include Jeremy Nugent, who's here, Lee Forsyth and Dr. Marcus Jackson. There you are. Also in the room today, so thank you for coming. It was also in this time that I co-delivered teaching to include the patient voice. And here I particularly want to acknowledge David Grant, who MSc alumni in the room will recall provided really memorable and challenging teaching sessions about hopefulness and rehabilitation, sharing his own brain tumour experiences and insights. I want to highlight here the uncertainty accompanying a mid-career move into education. I think we're starting to pay more attention to that. I think we need to strive to make this a less uncertain leap of faith and a more recognisable career development step, particularly for the allied health professions, because we need to encourage colleagues with rich and mature practice experience into the education setting as researchers, educators and leaders. Again, it's not just a steep learning curve for me, an abrupt realisation that knowing something and being skilled in it in practice is not the same as teaching it. Again, it was not just me taking that leap of faith, but also Fiona in appointing me. Like many of us, I'd invested mostly in my clinical and leadership pillars of practice and barely at all in my education and research pillars. We need to do more to encourage practitioners to develop the education pillar if we're going to secure future workforce supply, improve workforce retention, and make clinical academic roles something that all health professionals see as a possibility. Currently, the lack of shared metrics and career development currency between the NHS practice and the education sectors can mean colleagues are less well equipped to move into an educator role. And that can also cause career progression to stall when you have to prove yourself all over again as a leader in the education sector. Around 2011, my immersion in learning and teaching started to prompt a much greater uncertainty, and this time about supervision. Regulators like the Health and Care Professions Council say we need to understand the importance of participation in training, supervision and mentoring, and they also encourage our employers to be supportive of registrants in that way. Yet when I spoke to experienced practitioners, such as those studying the MSc, there was a ready acknowledgement that there was, and probably still is, a tendency in the context of crazy business of practice for supervision to get squeezed out of our diaries as patient-facing activity becomes the priority. And this uncertainty led to my PhD. This would never have happened without the initial encouragement of Professor Deborah Bowman, who became one of my supervisors, and I know she's tuning in today to listen. And in due course, Professor Annette Boaz, I'm so delighted to have you here as well, who became my second supervisor. Don't be fooled, Deborah and Annette come across as really lovely, gentle humans. They are as daunting as they are brilliant, humble and human. Somehow, when I thought I'd done my best thinking ever, they got me to do a bit more. I'm also grateful to others who were so supportive of this work, all my participants, Kathy Sparks for lighting that supervision blue touch paper at the beginning, Dr. Elizabeth Taylor for peer support as we both engaged in our PhD studies at the time, Carol Pound for your just being a fantastic human, frankly, and introducing me to PhD peers at City University, and to Dr. John Hammond, who's here, who along with Dr. Simon Fletcher, who was one of our colleagues at the time, helped me to prepare for my Viva with a rigorous mock. So in my research, I spoke to physios, speech and language therapists and occupational therapists. And we began not with questions, but I know many of you in the room will not be disappointed to hear that I began with postcards. People know how fond I am of these in teaching. And an invitation to find an image or images which might tell me something about supervision. About a third of the way through my data collection, I realised people weren't saying very much about supervision, which did make me think I was a pretty rubbish researcher for a bit. But they were saying an enormous amount about uncertainty. Their uncertainties were messy, ill-defined, and interwoven. But I suggest they fall into three broad categories. Those ones that are like our platform for practice. Do I know enough? Am I skilled enough? Am I experienced enough? The ones that are about practice demands. This work is burdensome and I have too much to do. And the ones that I call socio-professional. So do I look like a therapist, a team leader, a band 7, a respiratory physio, an oncology OT? And I also noticed some behaviours that are really helpful in resolving our uncertainties through learning. Not just resolving them, but recognising them and also working out which ones we might have to tolerate. Let me illustrate that a little bit in a little bit more detail. So these are the dimensions of practitioner permeability. And so for any of us as practitioners or professionals, it's about being self-aware, so recognising our own uncertainties, and awareness of and others, the implications of those uncertainties for practice safety. It's not enough for me to then hold on to those uncertainties. I need to be willing to share them with others if I'm going to resolve them. And also welcome feedback. Be open to alternatives, exploring other ways of learning and doing. To be critically aware, weighing up what works and is safe, and ultimately being willing to change or learn. So actually implementing those changes in practice. These dimensions of permeability are also important for supervisors. So as a supervisor, your self-awareness is in part about recognizing your own position and experience. Your awareness of and for others is about using that thoughtfully for supervisee and colleague benefit, but with an eye on public safety. Awareness sharing is about sharing concerns you might have about a supervisee, but also, and something we forget too often in supervision, celebrating successes with them. Feedback seeking includes welcoming feedback about yourself as a supervisor or an educator. And openness to alternatives means exploring other ways of learning and doing, and recognizing that also, although your supervisee might do things in a slightly different way to you, that's still potentially safe. Critically aware, weighing up what works again and what is safe, and ultimately willing to change. And for supervisors and educators, that's about us continuing to engage in our own professional development, including the education pillar. It's a spectrum. We might notice in ourselves or in others our tendencies to be more or less permeable. Times when we stick to familiar ways of doing things, even when they're not serving us very well. And times when we feel like we need more support, training, development, or reassurance. In a given day, there are times when we feel more or less permeable, times when we might be the only one in the team who thinks it's unsafe for the patient to go home, and we advocate for that patient, regardless of the different perspectives our colleagues are offering. What I do notice, however, is that being stuck at one or other end of that spectrum isn't helpful when we want to resolve our practice uncertainties. And I should add here that while I can spot the permeability thing, I'm not always very good at it myself. This isn't a new idea, as many of you in the room might be thinking. In the 1950s, Renee Fox talked about including training for uncertainty in the medical curriculum. But I do think the rise of evidence-informed practice has caused us to lose touch with the inevitability of uncertainty, although COVID potentially has brought us face to face with it again. I also suggest that in healthcare, we tend to think about uncertainty as a marker for risk, losing sight of the fact that it serves as an important prompt to learn. And I like what Webster Wright says about this. She writes about authentic professional learning happening when the professional is actively engaged in aspects of professional practice they care about, perceive as uncertain, and see as novel. So recognising this prompt to learn should be part of our approach to mitigating risk. So a PhD can serve a number of purposes, and I wasn't sure where mine was going to take me, but let's have a little think about where the new platform for practice has led. Undoubtedly for me, the PhD strengthened my academic threads and reconnected me with some of my speech and language therapy professional clinical foundations via Professor Lindy McAllister, who was visiting from the University of Sydney, Australia in 2017, who I'm very thankful encouraged me to collaborate in some research methods chapters for speech and language therapy research methods texts. I was really excited about a lot of the ideas that I'd come up with in the PhD and that had arisen from my data. And I had an aim to share those ideas, like the platform for practice and being permeable with colleagues, though not necessarily behind a paywall or in a hard to access publication. So materials arising from that work are freely available to download. It's not business, it's all free from my blog and website, which has been beautifully designed by Charlotte Duff. I've also really enjoyed collaborating with practice colleagues to apply the ideas in practice. Has been really gratifying. In this instance, with Arnie Puntis, who's here this evening, at that time clinical lead in St George's Trust, but now found doing great work at the NHS Race and Health Observatory. As we all sought to find new ways of being in 2020, in one of the Bridges webinars, Arnie and I shared thoughts about navigating the practice uncertainty associated with the early days of the pandemic response, times when we found it hard to be our most permeable selves. Perhaps what I had not anticipated was the work that followed with NHS Improvement, NHS England and Health Education England, the NHS arm's length bodies, all now coming together under the umbrella of NHS England. While I was still completing my PhD, a series of projects was commissioned from the Chief Allied Health Professions Office in NHS England, and many will recognise Suzanne Rastrick, the NHS Chief Allied Health Professions Officer, and I'm very honoured to have you here, Suzanne. Thank you so much for coming. And she's pictured here at faculty graduation in 2019, receiving an honorary doctorate from St George's. Starting in 2017 and commissioned then by Jo Fillingham from that team, Liz Treadwell, who's there in the front with the flowers, she's so attention-seeking. Liz Treadwell and I conducted an evaluation for AHP leadership across the NHS trusts in England, working collaboratively with Caroline Poole, who was Joanne Fillingham's clinical fellow. Joanne, I should say, is just sort of in the middle picture. She's pretty much in the middle of the screen there. And that led to two further pieces of work, which we produced in collaboration with Stuart Palmer, the AHP lead, as I said, at NHS Improvement at the time, who's pictured just above Liz in this slide. The three pieces of work which were produced from these projects are part of NHS England's leadership resources. It's fair to say we had a bit of a heart-sink moment when we first presented the work to Joanne, who responded to our initial evaluation with, kind of knew this, but then followed up, but we are now able to point to the evidence. And it's absolutely true to say I would have been reluctant to take this leap of faith to do the work without Liz as my partner. And it was Liz whose extraordinary attention to detail spotted a crucial correlation between the presence of senior AHP leadership in NHS trusts and higher rates of AHP engagement in service improvement. I think it's fair to say Liz and I are immensely proud of this work and our part in the development of AHP leaders in the NHS in England. And our relationship with Suzanne, I'm pleased to say, continues. We've done some recent work, again, which I began with Stuart Palmer and have completed with Janice St John Matthews, where we've been looking at strengthening the paramedic voice in this leadership work. Perhaps the biggest leap of faith requiring me to be my most permeable self has been developing the Health Education England Centre for Advancing Practice Guidance for Workplace Multi-Professional Supervision. We really had to think differently in this work. Advanced practitioners are highly experienced clinicians from across the professional registrations, trained to an advanced level, nurses, pharmacists, allied health professionals, midwives, and so on. Developing this workforce is supported by NHSE policy, but advanced practice is at very different stages of maturity across the NHS, professions, sectors, and specialties. This work has taken the idea of practitioner permeability to a whole new audience, with the permeability self-assessment making it, as you can see, into Appendix 4 in the guidance. Beverly Harding, whose Twitter profile is over there, so the AHP lead for NHS England and the national lead for multi-professional consultant and advanced level practice, and one of Suzanne's deputies, actually had to twist my arm pretty hard to get involved in this. I'm enormously thankful she did, and I currently bookend my week Mondays and Fridays as the supervision subject matter expert for the Advanced Practice and Allied Health national programmes, as well as being part of the multi-professional supervision reform network in the education reform team, where we're finding common ground for all professions: medicine, dentistry, pharmacy, allied health. There's sometimes some really unhelpful tribalism in the healthcare workforce, but I think we're beginning to make some really good progress by identifying the supervision fundamentals that apply across the whole workforce and all professions. The work is reaching across the devolved nations, and I have permission from Sylvia Hazelhurst and Claire Savage of NHS Scotland and NHS Highlands to say how this was their go-to reference when they've been developing work there. So we are beginning to see a second iteration of this work, and I should also put a huge thanks out to Claire Holt from Nice Tree Films, who helped us to craft some supporting films for this work during the really challenging lockdown circumstances. So advanced practice wasn't really my world, which was one of the reasons I was a bit nervous about joining in with this piece of work. But I think in this work, I've probably been something of a supervision magpie, gathering shiny supervision ideas and crafting them into coherent guidance. And these are some of my early and continuing collaborators. I'll leave them there for a moment so they can spot themselves, but I won't read through the whole list. So since the piece of work came out, I've been sharing a lot of those shiny gems across the system. There were some tough gigs, I have to say, but what I've discovered that even with paramedic colleagues and MSK physios, there is quite a huge appetite for this stuff, which is very gratifying. I want to pick out a couple of really lovely shiny gems in this work. First is Scott Ballard-Ridley from Bridges Self-Management, and I'm really pleased that Scott is with us this evening as well. He is my critical friend and collaborator in teaching we do together about learning with, for, and from patients as part of the MSc Advanced Clinical Practice. Scott really ensures all my academic and theorial wittering stays grounded and in reality by sharing how it relates to his own experiences of life before and after a stroke. It was great to share a snapshot of that work in the November 2020 Centre for Advancing Practice National Conference. Thank you for collaborating on that, Scott. And secondly, the SLT Time podcast. In their words, this is a podcast opening up discussions around race, ethnicity, and the lived experience of speech and language therapists and students from underrepresented and misunderstood communities. My thanks to them for inviting me to talk about supervision in this context, and to two of that team, Ilya Nadi and Sahar Nashir, who are crafting a chapter sharing their experiences and insights for a forthcoming book of supervision in speech and language therapy, personal stories and professional wisdom, which Kathy Sparks very kindly invited me to co-edit with her and colleague Sam Simpson. So you'll have seen me talk or heard me talking about pillars of practice, and in advanced practice we talk about capabilities across 4 pillars of practice: clinical, research, leadership and education. For colleagues starting their development in advanced practice, the education pillar is often the one they feel most uncertain about, and perhaps are not persuaded that investing in the education pillar is as valuable as clinical, research or leadership. So what's that fit between supervision and education? That's another thing that we sometimes worry about in this space. And there are undoubtedly some potential tussles. Is supervision a subset of education? Is education a subset of supervision? Is education instruction and supervision facilitation? Is education something developmental and supervision governance? Might supervision even be some form of surveillance? Increasingly, I think it's helpful to think about these terms as a knot, and not just in advanced practice, but in general, becoming a professional. I love what Dal Alba says here. Becoming a professional involves integration of knowing, acting and being in the form of professional ways of being that unfold over time. And so it's about our knowledge combined with our know-how and our knowing how to be. And it's that knowing how to be bit that I think we sometimes neglect. So I often think about supervision as the foundation of the education pillar, and I think there's a strong case for making it the first pillar, sorry Dan, as we address advanced practice development, not least because I think practitioners have the most ground to make up in that pillar. And that's because, generally speaking, the education pillar is not seen as a career development priority, either for individuals or for employers. It's not seen as having particularly large career progression value. Educators and supervisors tend to pick up their skills vicariously by adopting a what works for me approach or avoiding what didn't. And generally speaking, we're unaware of models or frameworks and never had any read any research or literature in the field. And I want to suggest that that's pretty unthinkable if we were talking about a clinical competence or capability. And yet it's the one thing our regulators encourage us all to do. So there we go. There's the paradox. It is the thing that our regulators encourage us all to do. And perhaps even more so, it's embedded in statute as an employer responsibility to support that competence, skills and experience development in order to keep people safe, and that there should be support, training, professional development, supervision and appraisals that will help us to carry out our roles and responsibilities in that regard. So what's going on? Are we setting the bar too high? Or are we asking too much of busy practitioners and a demanding curriculum? I actually think it's just that we've lost sight of the value of the education pillar, and my experiences running the Advancing Clinical Education and Supervision module in the MSc Advanced Clinical Practice here at George's bring me some hope. I'm persuaded that we are pushing on an open door and that practitioners recognise the transformative potential of the education pillar knowledge, as this feedback from colleagues suggests. So one of our advanced practitioner nurses who studied the programme said it completely changed her approach to delivering education. She was aware her approach was outdated, but didn't have the theory and tools to change it. And a primary care pharmacist here saying, I've not learned anything like this before. I thoroughly enjoyed the sessions, really an eye-opener. I've learned a lot about education and supervision. This module has definitely influenced the way I practice and will practice. So that prompted me in a keynote for the Association of Advanced Practice Educators last year to take a little look back at the first 100 students to complete this education module. As the word cloud suggests, we had really richly multi-professional cohorts, a lot of nurses, physios and paramedics, but dietitians, occupational therapists, operating department practitioners, pharmacists and radiographers, working in really diverse settings: primary care, MSK, emergency care, ambulance services, acute medicine and urgent treatment centres. Bear with me, there's quite a few here, but I'm very excited about them. So these are the sorts of themes that we found, I found in their assignments. Redesigning simulation learning in the emergency department and making that more practitioner-centred. What's the learning needs? Rethinking skills development. How do we learn to take a history, do an endoscopy, assess an eye injury, a closed distal radial fracture, pressure care assessment in the community? How can we be more humanising in those interactions with patients? Using theories and models to plan and support redeployment of the workforce during the first wave of COVID. Exploring our own role as an educator, exploring options to spot and support colleagues and trainees in difficulty. I love that. Designing workplace learning for emergency department colleagues to enhance patient-centred care for people with mental health needs. This is a great one. Examining incidents and complaints data to identify workplace learning and supervision priorities. This is the stuff we need to see more of, because it's really starting to connect the education piece and the practice piece, and joining up education and learning with safety. Again, the one at the bottom, drawing on our own reflections on a clinical incident to shape future learning for self and team, leading to redesigning and promoting new protocols. Couple more. Thinking about different approaches to medicines management and how that learning needs to differ for different people in the team in primary care. Thinking about how to ensure colleagues can raise equality, diversity and inclusion uncertainties in supervision. Encouraging collaborative learning in that transition to advanced practitioner. Drawing on action learning in a number of ways here as well. Rethinking patient education. So how do we teach intermittent self-catheterization, pain management, antibiotic use and so on? Can we redesign appraisals to ensure a really strong learning and development focus? Can we establish more interprofessional learning forums, overcome barriers to supervision in the hospital at night, maximise opportunities for workplace learning and supervision in complex clinical environments by drawing on situational learning? So I think there's a lot to celebrate, but there's a lot still to do. There will be more uncertainties, there will be more leaps of faith, more working on being my most permeable self. I want to close with 5 slides that draw on my own and others' thoughts, which I use quite a lot when I'm talking about the need to embed supervision and the education pillar in practice. Firstly, I like to think about supervision as a safe opportunity to share, explore and resolve practice uncertainties with a focus on maintaining and promoting professional and public safety through continuous professional learning. Secondly, as Bill Beckmo and colleagues describe, being a professional is a movement back and forth between supporting and letting oneself be supported, between confronting and being confronted, between pushing and being pushed. And as Revens reminds us, we might be cognitively aware of the need to behave differently and yet remain determined not to do so in practice. And Rout describes how we need to guard against decay of our knowledge and skills, retain critical control over the more intuitive parts of our expertise. They become more intuitive as we become more experienced and confident. And that's partly a matter of lifelong learning, but it is partly a wise understanding of our own fallibility. And perhaps most importantly, as Mabon, Cornwell and Sweeney, Mabon was one of my examiners actually in my PhD, as they remind us, really relating to patients takes courage, humility and compassion. It requires constant renewal by practitioners and recognition, reinforcement and support from colleagues and managers. So there we have it. We need to embed supervision and education pillar in practice because it's fundamental for professional and public safety. Thank you for listening.
so much. Yeah, my name is Fiona, and I'm very honoured and feel very privileged to do the vote of thanks today. And it was lovely when you asked me. I feel very pleased. Thank you, Debs. But also thank you all for coming. And there was just such a lovely buzz at the start as people were connecting after such a long time. And thank you to everybody online that is listening in, because I know that there were a large number of people that wanted to be here in person but couldn't be here in person. I want to just start by saying that today I asked some people who know you very well what they thought of you, how they would describe you. Some of this has been sanitised slightly for this evening, but here are some of the words that they used: open, supportive, curious, uplifting, energising, hilarious, smart, innovative, compassionate, embracing, warm. Chris, I hope you're recognising this to be Deb. Knowledgeable, inspiring. I have to just say that Annette said there's not many PhD students that come into supervision with a big smile on their face and describe it as a cognitive spa. And I think it's just actually some of the language that people used, it's worth just saying an actual quote, and this was from Sophie, and she said, "You have a great way of making us feel listened to." And in capital letters from somebody in the room said, "You are authentic and your impact is far-reaching." Now, I said I would sanitize some, but I couldn't resist saying this. So somebody described you as a wonder bra friend. It's there when you need supporting, uplifting, but then you also separate the truth from your own perception. A little while ago, I didn't know whether to say that or not. So the common theme for me, having known Deb since the 90s, is language and connectivity. Debs, you are the first SLT professor, and I think you should really celebrate that and own that. The timing of your work is not coincidental. These ideas have been percolating for a very long time. I can pay testimony to that, and I'm sure lots of you here can as well. But for Debs to apply this work in such a powerful way in the area of advanced practice, I would like to thank you on behalf of everyone you have connected with, who has benefited from that connection and will continue to connect with you and benefit from you. You really are just at the start of this, but there are a lot of people who are much more permeable because of you and your research. And I hope that was short enough, because I would now like to invite you not to ask questions, I've had that drummed into me, but to join us for drinks and chat and to celebrate with Professor Deborah Harding. Thank you.